Well, good evening. Welcome to our annual Prostate Cancer Awareness Program in partnership with AdMeTech Foundation. My name is Jillian Harvey, and I'm the president of the Mystic Valley Area NAACP, serving the communities of Malden, Medford, Everett, Winchester, Woburn, and Arlington. I'm so grateful for our partnership with AdMeTech Foundation and the availability of the Prostate Cancer Equity Program in Massachusetts. Prostate cancer is the most common major male cancer, affecting 1 in 8 American men, and Black and brown men, including Hispanic men, are 2.5 times more likely to die from prostate cancer, even though it's curable when detected early. This evening, you'll hear from some local leaders in our communities and state and medical experts about the steps you can take to educate and protect those you love against prostate cancer. Materials and resources will be shared and are available on the Mystic Valley NAACP website. So thank you for tuning in. And I do want to just mention and thank our Mystic Valley State House delegation as champions of the prostate cancer educational program for high-risk men, with the priority focus of African American and Hispanic individuals. And so we did have lined up one of our other speakers, introduce Jonathan Zuber, the president of Black Citizens of Lexington. And I would like to invite you now to speak, and you can share a little bit as well about the Association of Black Citizens of Lexington, which is a private nonprofit volunteer organization composed of academics, artists, lawyers, engineers, entrepreneurs, and others who are concerned with matters of critical importance to the welfare of Black citizens of Lexington, Massachusetts.
Okay, well, thank you for that introduction. As you said, my name is Jonathan Zuber. I'm the president of ABCL, Association of Black Citizens of Lexington. We have been in existence since our founding in 2018, become known for increasing visibility and awareness of the contributions of Blacks in the Lexington community. Some people primarily think of Lexington as a leafy white suburb with some growing Asian population, but there is also a strong, committed, although small, Black community in Lexington. And we are here to make sure that we thrive and we look out for each other and continue to stick up for our rights and to honor our history. One of the more recent ways we've done that is through the Black History portrait banners that we've, along Sean Osborne, one of our founders, started. He did some research on Black figures in Lexington's history, and from that we were able to create stories around those and construct some banners that we show in the town during February, Black History Month. You also notice that since that time, I think we started about 4 years ago, and we've done it every year since. Since that time, if you look in Arlington, they also have started a program. So we feel like we've done a lot to raise awareness of the contributions of Blacks to the history of this country, not just as enslaved people, but as founders and revolutionaries.
Great, thank you so much. And is there a way for folks to get in touch with you if they're looking for more information, or if they live in Lexington or are looking to get involved?
Yes, there is. So we have a website at www.abclex.org. So that's www.abclex.org. And on there should be a link to contact ABCL and request membership and join in our monthly meetings and social activities.
Great. Thank you so much, John.
You're welcome.
Next, I would like to invite our immediate past president of the Mystic Valley Area NAACP, Zane Crute, to say a few words.
Thank you, Jill. Appreciate the introduction. It's going to soon be to even more further distant past present now that Jill's going to be taking the reins and serving another term. So we're definitely thankful for that. So glad to be here tonight, all. I appreciate anyone tuning in on Facebook Live. I appreciate anyone here with us. I appreciate anyone who's going to watch this link later. I appreciate anyone who's going to share this to families, friends, and anyone that you know. I know it's a dark, dreary, rainy evening, so there's definitely no better place to be than to be absorbing this information with us tonight. So thank you all for being here. This is pivotal information for you to digest too. Before you digest too much turkey or football or family fun next week, why not digest prostate cancer awareness information with us tonight? So as Jill said, my name is Zane Thomas Crute. I work in banking by day. I also live in Belmont, Massachusetts, which is very close to John's town of Lexington. By night, I serve on the executive committee of the Mystic Valley area branch of the NAACP, which, as Jill stated, but to remind you, covers towns such as Medford, Arlington, Woburn, Winchester, Malden, and Everett, and by way of some other neighboring towns which were the closest branch to, such as Lexington. I also held the honor of being the president of this branch for 6 years preceding Jill, as well as serving as the secretary of the New England area branch of the NAACP, which covers all the branches in New England outside of Connecticut. So Boston, Providence, Martha's Vineyard, Newport, Rhode Island, Springfield, Massachusetts, Worcester. Don't want to leave anyone out, but a lot of the different branches across Massachusetts, Vermont, Rhode Island, New Hampshire, and Maine. Tonight, I want to invite men of color to be more active in their health. We're currently in the aftermath of the pandemic, which I know everyone was really sick of, wearing masks, getting vaccines. I know I was sick of it by day 2. Inflation is crazy. I don't know if anyone's ever checked the housing prices, whether in Lexington or anywhere in the Mystic Valley. Check the cost of travel, college costs, or daycare costs. We have an interesting political climate. I won't say any more, but I can go on and on. So, we got the challenges with the economy, challenges with health, challenges with everything. So needless to say, we have a multitude of different things to be stressed out about. So one less thing we should be stressed about is our health. And we can control this by taking a more active awareness in our health. Being a young man of color, unfortunately, we are the leading demographic in terms of a lot of negative health disparities. So to fight this, we want to ensure that we are doing what we can to be as healthy as we can. Prostate cancer is obviously more active in young Black men and young Latino men. So from this event, we want you to leave and be more aware of it, know where to get the resources, know that the AdMeTech Foundation is a good conduit of these resources, understand that specific age you should start getting tested, know if you should talk to your relatives, whether your father, your uncle, cousins, in terms of getting tested and taking their health serious. Prostate cancer is one of the leading cancers in young brown men. But that being said, it is 100% curable with early detection. You want to be aware of this. You want to take your health serious. You want to detect it early. And if you detect it early, you can definitely fight against it. So early detection is critical, as I said. You can beat this cancer with early detection. You don't want to get caught sleeping on your health. You might get caught sleeping on other things. Keep your eyes open and be aware. Health equity is a civil rights issue for us, for the NAACP. We want to ensure people of color in our communities are safe from health inequalities that disproportionately affect us, such as prostate cancer. The goal of this event is to empower individuals to take charge of their health and reduce health disparities of prostate cancer. The AdMeTech Foundation is a critical partner in this fight against prostate cancer. If you are higher risk, get detected early. Go out to continue to vote against things that undermine our civil rights. Continue fighting everything else the NAACP is fighting for. Become a member. Ensure you fight against prostate cancer. Thank you so much.
Thank you so much, Zane. And so next, we are going to hear tonight from Dr. Sean Wason, who has provided a video of his presentation as he was unable to join us live. Dr. Wason is a faculty member in the Division of Urology and at Harvard Medical and an associated position with the Milton Center for Specialty Care and Needham Urology Associates. He belongs with Beth Israel Deaconess Medical Center, Beth Israel Lahey Health, Harvard Medical School, and He will review advances in screening and diagnosis for prostate cancer.
My name is Sean Wason, and I'm a faculty member in the Division of Urology at Beth Israel Deaconess Medical Center. I primarily work out of Milton and Needham hospitals, and I'm a part-time lecturer at Harvard Medical School. I was asked to give a talk on advances in the screening and diagnosis of prostate cancer. I have no disclosures related to this talk. We all may know someone that's been affected by prostate cancer. For me, it was my grandfather, Ernest Wason, who grew up in the sunny island of Barbados, the easternmost Caribbean island. I dedicate this talk to him. The objectives of my talk are to review the goals of screening. Who do we screen? When do we screen? How do we make the diagnosis? And how are we using imaging and biomarkers to screen our patient? Typical patient that may present to me in my office for prostate cancer screening. He's a middle-aged male. He has a strong family history of prostate cancer. Notably, his grandfather died of metastatic prostate cancer, and he has a brother who was recently diagnosed with localized prostate cancer and is undergoing treatment. He has no significant voiding symptoms. He feels well. He works out frequently. He does have well-controlled hypertension, and he takes medications for this and a statin for his elevated cholesterol. He drinks alcohol occasionally. He doesn't smoke. He's married, and his erections are normal. He was noted to have a relatively normal digital rectal exam that was round, smooth, slightly enlarged, but his PSA was 4.5 nanograms per milliliter. I like to review the prostate anatomy with patients. The prostate is typically the size of a walnut, measures about 30 grams, and is part of the urethral channel. It's tucked in between the bladder and the rectum, and the backside of the prostate can be palpated by performing a digital rectal exam. The function is a reproductive organ, and it contributes to semen. What we do know is that prostate cancer is common. It affects 1 in 8 men in the United States. If detected early, the 5-year survival rate is nearly 100%. The goals with prostate cancer screening are to minimize the detection of non-life-threatening cancers and maximize the detection of intermediate and high-grade cancers, as well as decrease the unneeded biopsies and treatment. As established by the American Urologic Association on the early detection of prostate cancer. What we mean by early detection is screening, and both imply detection of a disease at an early pre-symptomatic stage when a man would have no other reason to seek medical care. The panel recommends against PSA screening in men less than the age of 40. In this age group, there is a low prevalence of clinically detectable prostate cancer. The panel also does not recommend routine screening in men over the age of 70, unless they are in excellent health and they may benefit from screening. The panel strongly recommends shared decision-making for men in between the ages of 55 and 69 with either their primary care physician or urologist, and then proceeding with screening based on a man's values and preferences. How do we find prostate cancer? The 2 most common ways are a blood test measuring PSA or prostate-specific antigen, as well as a digital rectal exam. Screening is best performed when these 2 are taken in combination. Typically, PSA and digital rectal exam are done annually for screening, but this does not tell you if someone has prostate cancer. You need a prostate biopsy in order to make the diagnosis. PSA stands for prostatic-specific antigen. It's a protein in the semen that liquefies the ejaculate. It circulates in the blood of all men with intact prostates. The good news is PSA is only made by the prostate. However, prostate levels can be elevated for several reasons, such as inflammation, trauma, or natural enlargement as men age. I think a lot of men need to know, what is your PSA and what is the trend? What is the velocity? How quickly is it rising? One of the earliest known biomarkers used in urology. It's used in several phases of the disease, including screening, diagnosis, after local treatment, in advanced as well as metastatic disease. In regards to PSA screening, from a urologist's perspective, most would agree that mass screening is in the past. PSA does have several limitations. It's not a definitive test for prostate cancer. Shared decision-making is important. High-risk patients, such as those with first-degree relatives and family members, should be considered for screening. Age and comorbidities will often dictate who gets screened. which is also dictated by primary care providers. Who gets biopsied and diagnosed is often dictated by urologists. The National Comprehensive Cancer Center also has their guidelines on the early detection of prostate cancer. If a PSA is less than 1 nanogram per milliliter and there is a normal digital rectal exam, repeat testing can occur at longer intervals. If a PSA is in between 1 and 3 with a normal digital rectal exam, repeat testing should occur at 1 to 2 year intervals. If a PSA is greater than 3 or there's a suspicious nodule on digital rectal exam, the PSA should be repeated and this patient referred for possible biopsy. In these patients, we would consider the use of multiparametric MRI as well as biomarkers. If there remains a high suspicion for prostate cancer, these patients should undergo prostate needle biopsy. If there's a low suspicion for prostate cancer, the PSA and digital rectal exam can be repeated at a shorter interval. In my practice, I often use transabdominal ultrasounds to determine the size of the patient's prostate. By taking the PSA divided by the prostate size, we can determine the PSA density. The denser the prostate is, the more concern there is for prostate cancer. Biomarkers available for risk stratification in patients with suspected or known prostate cancer. Biomarkers are biologic molecules typically found in blood, urine, or tissue that can be used as a marker of normal or abnormal processes within the body. Biomarkers can be used in all aspects of patient care. They can be done before a biopsy, prior to repeat prostate biopsy, after biopsy, or post-treatment. Biomarkers should, however, not be routinely used in all patients. I use SelectMDx, which is a urine-based biomarker in my practice. I will use this for patients that have had a negative prostate biopsy in the past. Those patients with a very large prostate with a smaller concern for prostate cancer, and those patients that may be in the gray zone or hesitant to proceed with prostate biopsy. The assay looks for 2 genes, HOXC6 and DLX1, that have been shown to be associated with prostate cancer. Findings associated with the digital rectal exam, the PSA, the patient's age, and the prostate size are combined into a report that tells us the likelihood of finding prostate cancer upon biopsy, as well as, more importantly, the likelihood of detecting a clinically significant prostate cancer, which is considered a Gleason 7 or greater. I will also typically use multiparametric MRI frequently in my practice. In patients considering a prostate biopsy, all patients will undergo a multiparametric MRI, which stands for magnetic resonance imaging. There are several sequences performed in the MRI, and we can evaluate the MRI for suspicious areas within the prostate if there is evidence of extracapsular extension, seminal vesicle involvement, lymph node involvement, or possible bony metastasis. The radiologist will give us a score, PIRAD score, from 1 to 5. And I think it's extremely important for men to know, what does my MRI show? Does it show any PIRADs 4 or 5 lesions? And where are the lesions? Another imaging modality that is currently being employed is microultrasound. This is a high-resolution ultrasound probe that provides real-time images similar to a standard transrectal ultrasound. This can be used in both the initial biopsy phase and the surveillance phase on patients diagnosed with prostate cancer. The images provided by microultrasound are far superior and can provide detailed local anatomy. It also has a very similar scoring system to the PIRADS system called PRIMUS. The higher the number on the PRIMUS score, the higher likelihood of finding clinically significant prostate cancer. Prostate biopsy is typically performed transrectally, and the goal is to sample the peripheral zone of the prostate. On average, 12 cores are taken, 6 on either side, in the peripheral zone of the prostate. The prostate biopsy will tell us, is there prostate cancer or not? What is the Gleason grade, which is the aggressiveness of the prostate cancer? Gleason 6 prostate cancers are the least aggressive, whereas Gleason 10 prostate cancers are the most aggressive. The prostate biopsy also estimates the volume of the cancer, the number of cores involved, what is the location, and if there is perineural invasion, which is a poor prognostic indicator. There are two standard ways to perform a prostate biopsy. One is via the transperineal, and the other is via the transrectal route. Both are typically performed in the office, under ultrasound guidance, by a urologist. The added benefit of performing the transperineal biopsy is that anterior aspect of the prostate is more easily sampled. There may also be a slight decrease in the risk of infection via the transperineal route, although recent data is questioning this. Multiparametric MRI ultrasound fusion is a technique used to sample lesions noted on MRI. After the MRI is complete, the radiologist will encircle the lesion on the MRI, and then these images can be fused in real time to a standard transrectal or perineal ultrasound to ensure that the lesions that are noted on MRI are sampled. As prostate cancer can be found 15 to 20% of the time in other areas of the prostate without a lesion, usually the fusion-guided biopsy are also performed with the standard 12-core needle biopsy. After the prostate is sampled, the cores are all sent to a pathologist for evaluation and are given a Gleason grade, which ranges from 6 to 10, 10 being more aggressive. Patient needs to know, what is my current Gleason score? Once we know the Gleason score, the number of cores involved, the PSA, the digital rectal exam finding, the patients are given a risk category ranging from very low, low, intermediate, high, and very high risk. This will determine the extent at which imaging studies need to be performed for evaluation of disease outside of the prostate. In patients with low and favorable intermediate risk disease, genomic biomarkers can be performed on tissue removed at the time of biopsy. This will determine the biologic aggressiveness of the prostate cancer. This is useful for patients considering active surveillance. In patients found to have unfavorable intermediate risk, high risk, and very high risk disease should undergo additional imaging to ensure that there's no metastatic disease or disease outside of the prostate. Traditional imaging includes CT scan of the abdomen and pelvis, as well as a bone scan. Although CT and bone scan are still widely being used for imaging, slowly this is being supplanted by a more sensitive test called PSMA PET scan. PSMA stands for prostate-specific membrane antigen. This is a protein found on the surface of most prostate cancer cells. A radio-labeled pharmaceutical agent is tagged to PSMA. The whole body is scanned, and this will easily identify areas outside of the prostate where there may be prostate cancer metastasis. After a diagnosis of prostate cancer, many men will ask, how can I be proactive in my fight against prostate cancer? One of the fathers of prostate cancer treatment is Professor Laurie Klotz from the University of Toronto. He recommends smoking cessation, consider a low-dose statin, vitamin D supplementation, as well as metformin. In summary, prostate cancer is common and its aggressiveness is quite variable. Earlier detection is favorable and can lead to a cure a lot of the time. Our goal with prostate cancer screening is to maximize detection of intermediate, high, and lethal cancers, minimize the detection of non-life-threatening cancers. We can do this with improved imaging and genomics, which can improve risk stratification. This has also allowed urologists and patients to be more comfortable with active surveillance. Thank you for your attention.
Great. That was a wonderful presentation. We really appreciate all that information. Have to let that soak in a little bit. And so right now, I would like to pass it over to our final speaker, the president of AdMeTech Foundation, Dr. Fania Stern, who will share more details about the prostate cancer equity program.
Thank you so much, Jill. Zane, Jill, thank you so much for partnership for a number of years. And it's a pleasure for us to work with you and to bring information about prostate cancer to members of NICIPALI and NACP and many other people you invite to this event. So thank you so much for the opportunity. I also want to acknowledge Thomas Satam, our Director of Policy and Operations, who is here, and Emma Coyer. I will talk to Emma in a few minutes. We started actually preparing videos of my presentation because in the past we had a lot of technical problems with internet instability. And I would like to ask Emma to start my presentation.
My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. My gratitude to the Mystic Valley NAACP for a long-standing partnership that made this event possible. The focus of my talk is on the AdMeTech Foundation history and our prostate cancer programs established to lead and implement the cutting-edge advances in patient care and to bring them to all Massachusetts men with the goal to eliminate health disparities. AdMeTech's ongoing statewide program in prostate cancer created a Massachusetts model of national leadership in public awareness, medical education, research, and health equity. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. We are grateful to the Mystic Valley delegation to the Massachusetts State House who have championed our programs and made them possible.
History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of Diagnostic Imaging Research Branch at the National Cancer Institute. In this position, I was leading development of national and international policy and related strategy and programs for the National Institutes of Health, NIH, Department of Health and Human Services, and U.S. federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound, and molecular imaging for improved patient care. We also work on teleradiology for image transmission so that we could bring world-class expertise to underserved rural and remote communities. As of early 90s, most women had blind biopsies. Precision imaging made it possible to see where suspected tumors were located and develop stereotactic biopsies where biopsy needles are guided with precision to suspicious areas. As of early 90s, women with breast cancer have radical surgery or mastectomy where the entire breast is removed. A procedure performed in operating rooms causing physical, emotional trauma, pain, suffering, and deformity of women's bodies. Precision imaging made it possible to proceed with minimally invasive surgery or lumpectomy, where we identify and remove only a part of the breast tissue containing tumors. These minimally invasive procedures are performed in outpatient clinics with minimal complications, pain, suffering, and costs. As of early 90s, many women, particularly Black women, were diagnosed with breast cancer in more advanced stages and were more likely to die. With digital mammography and MRI, all women are more likely to have early detection of breast cancer, critical for saving lives. Today, Black women have a nearly equal chance of dying compared to white women in many communities, particularly in a state like Massachusetts with its universal access to care. In 1996, while our breast cancer programs were well underway at NCI and NIH, I brought together the key leaders of government, medicine, and industry to outline new strategic priorities. This expert recommended prostate cancer as the next priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer is among women. Prostate cancer strikes 1 in 8 men. Breast cancer strikes 1 in 8 women. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or the likelihood of men dying of prostate cancer. However, men did not have accurate diagnostic tools that would make it possible to sort out if an abnormal screening result is due to false alarm or due to a life-threatening prostate cancer. With no accurate diagnostic tools, many men had either insufficient diagnosis and treatment of aggressive prostate cancer with dangerous consequences, or on the other side of the spectrum, they had overdiagnosis and overtreatment of benign and harmless prostate cancer, leading to unnecessary invasive procedures with related life-altering complications and costs. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to a prolonged hospitalization, difficult recovery, and the unacceptable level of life-altering complications. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, in sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care and eliminating health disparities. At about the same time in 1996, I had a personal experience that left me shaken. A leading clinical expert in Massachusetts, chosen by me, saw my father and determined that he had a benign and common prostate condition. However, when my dad had an invasive procedure for this condition, he was found to have prostate cancer. I was shocked that a leading expert in a world-leading hospital did not have diagnostic tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of this disease for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I organized other leaders of medicine, and we approached NCI and NIH, key leaders, in a hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track record and a year-long effort, we did not succeed in convincing federal government. Consequently, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. Since 1997, we have been leading a pioneering research that resulted in creating precision MRI, molecular imaging, and other diagnostic tools that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, Where is Manogram? Prostate imaging for men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, a leading health disparity and public health priority. By 2013, again per our advocacy, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a standard in patient care. Since 2014, we expanded our efforts in public awareness, reaching countless men. At that time, Plymouth County had the state's highest mortality in Black men and the highest disparities. Black men in Brockton and Plymouth County were 2.7 times more likely to die compared to white men. We joined efforts with Brockton NAACP and Good Samaritan Medical Center. Under the leadership of Steve Bernard, Phyllis Ellis, Leona Martin, and Janet Trask, Brockton NAACP ensured a broad community engagement, mayor's office, city council, local media, and multiple local community organizations. By 2021, we had seen a significant reduction of overall prostate cancer mortality for all men in Plymouth County, but a particularly great impact on Black men. Since that time, we have seen a significant drop in health disparities in Plymouth County, while health disparities at the state level have not really changed. Today, Black men's chance of dying of prostate cancer compared to white men in Plymouth County dropped by more than 50%. In 2016, we established Global Summit for Medical Education with the goal to integrate imaging with other emerging diagnostics, including molecular and genetic testing, to ensure precision care that was tailored for individual men. Similar to breast cancer, precision imaging paved the way for image-guided, minimally invasive treatment for prostate cancer. Similar to lumpectomy, these minimally invasive procedures can be performed in outpatient clinics with minimal complications, discomfort, and cost. Several years ago, in 2021, we created Prostate Cancer Equity Program to deliver high-quality, world-class patient care to all men in Massachusetts, with the priority focus on Black men.
For public awareness campaign, our messaging centered on the importance of screening and early detection with blood test PSA, critical for saving lives. Since 2019, we reached well over 60,000 people. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive during the same period of time. PSA blood test used for screening of prostate cancer has been more successful in reducing the loss of life than any other cancer screening tools available today. Screening and early detection of prostate cancer are the best equalizer for all men.
The centerpiece of AdMeTech's medical education is annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. There is not a corner of the world that has not been represented at our summit. The latest 8th annual conference took place only a few weeks ago.
Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Dr. Rayson described them at length. Without equal access to these advances in patient care, We will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Supporting organizations include Latino Health Insurance Program and multiple branches of NAACP located across the state. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities, particularly when combined with our large-scale public education and awareness campaign. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in our program take care of our families and friends. This process consists of three main components. First, AdMeTech Foundation team members collect basic information and match individual patient needs with the appropriate state experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, and financial assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. We asked Ken Reeves, president of Cambridge NAACP and former mayor of Cambridge, to share his experience with prostate cancer equity program.
My name is Kenneth Reeves. I am the president of the Cambridge branch of the NAACP, as well as the former mayor of the city of Cambridge, Massachusetts. My intention is to say a word about the AdMeTech Foundation and its offerings and benefits, particularly to communities of color and particularly to Black men facing issues with respect to prostate cancer. I would say that in Cambridge, we've been in the men of color health business for more than 25 years. And so we have a men of color health outreach. However, I think we've become much more knowledgeable about ways in which we can assist the men of our city. And we particularly have become much more knowledgeable about prostate cancer and its impact on particularly Black men, who are 5 times as likely to be affected by prostate cancer than white men. So that being the case, and I've dealt with prostate cancer theoretically, and then 4 years ago, I was diagnosed with prostate cancer. So I have my own journey. And after diagnosis, I was able to hear what my treatment options were. And I chose something called CyberKnife, which is a 6-day treatment where you go every day for about an hour. There is a laser approach to the cancer. And after that, I was able to be clear for almost 2 years. And then suddenly my PSA or prostate specific antigen number kept going up, and no one could figure out why. And I had many MRIs and other tests. And that's when I met AdMeTech, because I was describing this to a friend, and they said, "You sounds like you're lost in the maze of, what to do when your numbers are inexplicable." So I was in touch with our Dr. Stern, and basically I had to tell her there is a test that they don't have in Boston that I need to have. It's an imaging test. It's very advanced. It's in Europe, but not yet approved by the FDA. And she said, "I'll get it for you." And she was able to arrange it through Sloan Kettering in New York. So after much red tape and bureaucracy, I was able to get that imaging test, and it did find where the prostate cancer had moved to an area around my lung, which my doctor, who's a very important, famous department head at Dana-Farber, said he had only seen one case in his career, so he was pretty sure it wasn't to the lung. So I then learned that, the physicians are great, but they're not God. So I called him and said, "Guess what? I'm number 2. And after being number 2, I still have had to have these various questions that I don't feel competent to answer about what next steps should be in my medical care. So while I have a wonderful team at Dana-Farber, who Dr. Stern led me to, but even in all that wonderfulness, there are questions that I don't feel competent to answer. So she just 2 days ago helped me to answer 2 great big questions. So I think this is timely for you to hear that. In my big questions were whether I should participate in a particular study, which would, I'm now on a very expensive pill that has my PSA number at 00000. So this is $16,000 a month. And the question asked of me by my doctor is whether I would participate in a trial which would essentially stop this pill, let the cancer come back, and then observe what that does with respect to the testosterone level. And the doctor also said, well, we don't get many Black men in trials, so we'd like to get it would be important if you were to say yes. And so this was hanging over my head like a cloud. I couldn't decide, because I want to do whatever I can do that will be helpful to both science and to prostate cancer with respect to Black men, because self-interest is a wonderful motivator. Her immediate reaction was, "Not for you, because you had one of only 2 cases with your particular doctor. The experience with people like you for such a trial is too small. And so you should be very thankful to the doctor, but it's not for you." Thank God for having a foundation that's devoted to navigating men of color through the maze of prostate cancer to be able, with a scientific point of view, give that kind of direction and consultation. So I must say that is great.
Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention. Thank you again. Emma, do you want to say a few words?
Hi, everyone. As Dr. Stern just mentioned, my name is Emma, and I'm the manager of the Prostate Cancer Equity Program. So if you were to call in or email the program, I would be the first one that you would connect to. And I just want to offer a call to action to you tonight that this program is here for you and can support you through every step of your medical journey. If you have any questions, if you have any concerns, if you'd like a second opinion, or if anyone in your life, any friends or family members have any of those concerns, please reach out to us. I'm going to put my information in the chat, and we're here to support you through every step of whatever you're going through, and you're not alone in this fight. So thank you so much for having us tonight, and I hope everyone has a good rest of your night.
Thank you so much, Emma. What I would like to highlight is that of all medical conditions, prostate cancer is one of the top 4 health disparities in medicine. 2 of them are maternal health and infant mortality. Third one is common for men and women, diabetes. In men, prostate cancer is a leading health disparities, and we are looking forward to expanding our partnership with Mystic Valley and ACP so that we will be able to make the kind of difference for Mystic Valley that we have made in Plymouth County. Emma and I will be happy to answer any questions. Jill, back to you.
Great. Thank you both so much for all of this information. Dr. Stern, the information you shared is invaluable, and I hope that everyone who joined us tonight or will be watching this afterwards, will share this information with neighbors, friends, family, any loved ones. The Prostate Cancer Equity Program is a resource that men in our communities and across the Commonwealth should take advantage of, and be in touch if they have questions. And I just want to thank you again for our speakers this evening. Thank you to our dedicated local leaders and all of those who are championing for prostate cancer equity. And lastly, I just want to thank you all for tuning in to this program. And again, if you have questions or are looking to get connected with someone within the program, you can reach out to us at the NAACP. Our email is info@mva-naacp.org. And Emma also shared the information as well to contact her directly. So other than that, I want to say thank you. And if anyone else has anything they want to say, you're more than welcome to. Doesn't look like it. Well, thank you again. And if there's no questions, then we will say goodnight to everyone.
Have a good evening. Thank you so much. Thank you for the opportunity. Thank you.
Thank you.